Hello and welcome to Health Talk. I'm your host, Angela Baracco-Eddy. With me tonight is Dr. Carl Speer. He is a board-certified gastroenterologist with the Baptist Division of Gastroenterology Associates. And you can find him at the Endoscopy Center on Davis Highway, as well as Baptist Hospital and the various offices that Baptist has around town. Gulf Breeze Hospital, they have one in Navarre. Where else? They've got him at 9 Mile Road, kind of all over
around
the
Davis
place.
Highway as well.
Yes, Davis Highway at the Endoscopy Center, of course. Tonight's topic is colon cancer screening. So we will be talking about screening colonoscopies. If you have any questions about that this evening, Wednesday night, we are live. So if you have any questions or comments and you'd like to have that answered, or you'd like to discuss something on the air with Dr. Speer, give us a call. The numbers will be on the screen throughout the program, 432-7768. Or if you're outside of the Pensacola area, the toll-free number is 1-800-950-2522. And again, you can certainly give us a call at any point during the program if you have a question about gastroenterology in general, or more specifically about colon cancer or colon cancer screening colonoscopies. So we'll get started with the basics, and of course, as we get into the program a little bit more, we will continue to get more and more detailed. But we will start off with the basics of what is gastroenterology first.
Well, gastroenterology is the study of the digestive system, and we cover 7 organs, including the esophagus, the stomach, the small intestine, the gallbladder, the pancreas, the large intestine. And we follow diseases that can affect any of those organs, of course, and we do endoscopy, which is a fiber optic scope that we introduce to look if we're doing an upper endoscopy into the esophagus, stomach, and proximal small bowel. We have scopes that look farther into the small intestine. We have the capsule camera that looks or takes pictures of the small intestine throughout its entire length. And then, of course, the colonoscopy to look at the colon. And we do various procedures to evaluate the liver, the pancreas, the gallbladder, and that sort of those other organs. We do ERCPs, which are diagnostic tests of the bile ducts, and endoscopic ultrasounds to evaluate the pancreas and the liver. So we have various tools to evaluate the different organs that we cover as far as our subspecialty. One of the biggest incidences of cancer that we've been able to make an impact on is colon cancer. And we've noticed over the last 5 to 10 years that the risk of colon cancer has actually decreased about 30% across the United States. And we like to attribute that to heightened screening for colon cancer, and that's our topic of discussion tonight. And we'll talk a little bit about how we do that and who's at risk and the target populations that we try to focus on. And there are some parts of the population that have a much higher risk than others, so those we want to concentrate on. And we screen earlier than the typical patient. So just things to discuss tonight.
Absolutely. Let's start off by kind of defining what is a colonoscopy? What is involved in that procedure itself?
Well, the colonoscopy allows us to inspect the colon visually through a fiber optic scope. And so this is pretty much the gold standard of colon cancer screening, because we like to see what's in the colon, and if it's something that is abnormal, we biopsy it. If it's something that may turn into a colon cancer later, we like to remove it, and we can do this through the colonoscopy. So the test involves a prep, and this is something that you drink to get everything cleaned out of your colon so we get a good look. And the better the look, the higher the chances of finding anything that needs to come out. And so we know most colon cancers start as a polyp or a small growth in the colon, and certain polyps are more precancerous than others. Most of the time, we have to remove them to know which ones are more prone to develop colon cancer. But sometimes we can tell just by inspecting them visually. So this whole process really hinges around a very good prep so we can see what's there. And if they're polyps, we take them out at the time of the colonoscopy, send them off to the lab and see how they look. This combined with family history and the patient's age then determines how often you have subsequent colonoscopies, because typically you don't just have one and you're done. If you have a risk factor, we're going to want to look in your colon frequently because that risk is there, particularly if you're one of those patients that has a familial colon cancer history, that risk is always there because of your genetic makeup. So we're going to want to look in your colon maybe even every 3 years or so. And in all likelihood, we'll find polyps along the way every time, take them out. And when we do this, we think we know we're reducing the risk for colon cancer by taking out these precancerous polyps. So a lot of the follow-up depends on the history, what we see on the initial endoscopy. But again, it starts with an adequate prep. So the colonoscopy, you come in, you take your prep beforehand. You come in, we start an IV, and for most folks, you're sedated or asleep during the procedure, and we have very good anesthesia. The procedure is a breeze if you're a patient. The hard part is the prep. We've tried to simplify that quite a bit, and we have various combinations of things that we have you drink depending on your experience in the past in underlying medical problems. If you have kidney disease or some other medical issues, maybe congestive heart failure, we may pick one prep versus the other, but we try to tailor that to the individual patient to get a good prep so we can get a good look. And then when you come in, the procedure can take anywhere from 20 minutes to a little shorter or a little longer depending on what we find. And then you wake back up and you go home, and we let you eat afterwards. With our present anesthesia, you wake up pretty refreshed. We don't let you drive, but we let you do pretty much anything else, including stopping and eating along the way home. And most people will just stop at the first place they see to have something to eat because you're pretty hungry by the time we're done. But for most folks, it's a pleasurable, not a pleasurable experience, but not an inconvenient experience. And you can just go about your business pretty much once we're done. Everybody can generally go back to work the next day. So it's really a small price to pay for the benefits that we obtain by doing a colonoscopy and determining what your risk for colon cancer is.
Let's talk a little bit about the various screening tools that are available. Colonoscopy is one.
Right. Colonoscopy is pretty much the gold standard, but over time there have been other screening methods developed, and this is particularly for patients who either can't or won't have a colonoscopy, or maybe their risks are too high. Their other medical problems would preclude them from having a colonoscopy. So there are 3 basic stool tests that are available, and the oldest is the stool hemocult, which is based on a guaiac test, where you submit 3 stools and it's tested for blood in the stool. If it's positive, then that's a flag that there may be something going on in your colon, i.e. a cancer, although not necessarily always a cancer. It could be other things, an ulcer, it could be a smaller polyp that may be bleeding, it could be inflammatory bowel disease. But a positive stool guaiac test requires further evaluation, usually a colonoscopy. The sensitivity of the stool guaiac test is about 40% for detecting cancer, so not a really high sensitivity rate. Most recently, there's been the fecal immunochemical test, or FIT, which is 2 stools that you submit, and it's a little bit more sensitive. It's an antibody to the globin portion of hemoglobin, so it's a little bit more sensitive for picking up blood in the stool, with a sensitivity of about 79 to 80% for detecting cancer. It's a little bit more expensive, and then really more recently has been the Cologuard test, which is a combination of the FIT, the fecal immunochemical test, plus detection of various mutations that we think are associated with colon cancer that we can detect in the stool. So the Cologuard is one submission, and of all the Cologuards, about half of them are negative. And out of the ones that are positive, about 30% will be a small polyp that's probably not significant but needs to come out, or several small polyps. About 20% will be fairly large polyps that are definitely precancerous that need to come out. And about 3 to 4% will be a colon cancer. So any positive Cologuard test really does require a colonoscopy to see what's there. It has a false positive rate of about 13%. And I have to admit, of all the positive Cologuards that I've done a colonoscopy on, none of them have had a colon cancer. And if they're positive, it does create a lot of angst in the patient because they think they have colon cancer. And again, a false positive rate of about 13%. But if it's positive, there's a good chance that you're going to have some polyps that need to be removed anyway. So it's for those that initially don't want a colonoscopy, it pretty much convinces them that they need a colonoscopy, and there's at least half the time there's something there that needs to come out. Not necessarily a cancer, but something. And it could also be other things that cause your stool to be positive for blood, including ulcerative colitis, Crohn's, maybe some ulcers caused by non-steroidal anti-inflammatory drugs. So there are all sorts of possibilities.
And a lot of times, if it gets to the point where there's blood in the stool, that's already pretty far advanced if it is a cancer, correct?
Yes, but there's so many different reasons for blood in the stool. You always think about cancer, you always want to look, but in all likelihood, it's probably not going to be cancer. It's going to be something else. But we need to look anyway. It could be, but you don't want to miss the chance that it is.
Right.
So if you're seeing blood in your stool, you need a colonoscopy, particularly if you're over the age of 50.
What are some of the other ways that you can test? Are there blood tests that you can test?
There are, and over the years there have been different blood tests. The most recent is called the EpiPro-Colon, and this is it tests a mutation. It's a methylation of one of the septin9 promoter gene that's associated with colon cancer. And I'm not sure of the price, but its sensitivity is actually about 60 to 68%. So it's actually not quite as sensitive as the fecal immunochemical test. So it's somewhere between the stool guaiac and the FIT test as far as sensitivity. But for folks who don't want to submit a stool, and unfortunately there's the yuck factor of having to collect your stool and send it off to a lab. Some people just don't want to do that. So this is not a bad alternative for those that are faint of heart and don't want a colonoscopy and don't want to do any other tests. And it's simple, but certainly if it's positive, you need to have a colonoscopy. So that may be helpful in convincing people that are somewhat reluctant to come on in and have a colonoscopy.
And the colonoscopy kind of screening guidelines, let's talk a little bit about that. Let's talk first, I guess, about the risk population. Well, I'm going to go backwards. Let's not talk about risk yet. Let's talk about the basic guidelines, then we'll talk about if you're at high risk, what changes.
Okay.
So basic guidelines.
So the basic guideline is everybody over the age of 50 needs a colonoscopy. If there is a family history of colon cancer or even a family history of polyps, we may start a little earlier, particularly if there's a family history of one of the colon cancer genes. And when you look at all colon cancers, about 30% of them are thought to be genetic, but unfortunately only 5% are associated with a known genetic factor. So there's this 25% of colon cancers out there, we just don't have a clue what their genetic makeup is, but we know that they are at risk. So if they have a family history of colon cancer, we would generally start about 10 years before their relative that had colon cancer was diagnosed at. So for instance, if your relative was 40 when they had colon cancer diagnosed, we'd start at 30. There are other ethnic groups that are at higher risk. We know with African Americans, they seem to have colon cancer a little earlier than 50. 50 is kind of the target population after which the risk goes up. But for African Americans, it's probably somewhere between 40 and 45. So there is a push to start screening them earlier, and we actually have some primary physicians that refer them earlier. Unfortunately, most insurance plans aren't on board with this plan, but we try to do it anyway. And unfortunately, for African Americans, not only do they have colon cancers earlier, but they tend to have colon cancers at a far advanced stage when they're first diagnosed, probably because they didn't have a screening colonoscopy earlier, and their mortality seems to be higher for unknown reasons. Hispanics also seem to have a higher risk for colon cancer than the average population, and obese patients. Obesity is a significant risk factor that we'll talk about later. They probably should be screened earlier as well, although that's not actually in the screening guidelines.
It's time for us to take a quick break. We've got a lot more information. We will get right to it as soon as we come back with more health talk.
Your word is gastroenterologist.
Can I have the definition?
A physician who specializes in diseases of the digestive tract.
Can you please use that in a sentence?
When stomach pain persists, you should see a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
G-A-S.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me tonight is Dr. Carl Speer. He is a board-certified gastroenterologist with the Baptist Division of Gastroenterology Associates. And you can find him at the Endoscopy Center on Davis Highway, as well as Baptist Hospital, Gulf Breeze Hospital, their medical park in Navarre or on 9 Mile Road. And tonight's topic is colon cancer screening. We've been talking a little bit in depth about colon cancer and the screening process. We have a lot more information to share with you. But we also want to give you the opportunity to share some information with us. Tonight, Wednesday night, we are live. So if you have a question or a comment for Dr. Speer, give us a call. The numbers will be on the screen throughout the program, 432-7768. Or if you're outside of the Pensacola area, the toll-free number is 1-800-950-2522. And I also want to mention the Endoscopy Center's website. They have a fantastic website there that's www.endo-world.com. Endo-world, there it is on the screen. They're so good about that. If you have any questions or if you want to make an appointment at one of the different offices, certainly check out that website because they have all of the contact information. They have information on the physicians. They have some frequently asked questions, some more information about the different procedures, things like that. Links to other websites also to kind of get you more information. So it's very helpful. If you have any questions or if you want to check it out, that's a great place to get started. And of course, all of the contact numbers are there for any of the offices, and you can certainly go through that website to get in touch with the physicians. So tonight again, we are talking about colon cancer screening. We were talking before the break a little bit about the risk factors, the at-risk population. The basic age is age 50 to begin to start your first colon cancer screening test, your screening colonoscopy. But there are some risk factors that might change that age a little. We talked about a few before the break. Race has something to do with it. Mm-hmm. Some family history definitely has something to do with it. What are some other risk factors that might change that first screening age?
People that have chronic inflammatory bowel disease tend to be at a higher risk, and it tends to occur with the length of time that they have inflammation occurring in their colon. So this includes people with both Crohn's disease and ulcerative colitis, and they have a little bit of a different genetic component to their colon cancers. But we start screening people that have had chronic ulcerative colitis, which involves just the colon, and people with Crohn's colitis that generally involves mostly the colon, although we also have involvement of the small intestine in Crohn's. They may be at an increased risk for small bowel cancer as well. But both people with Crohn's and ulcerative colitis, if it involves the colon, and they've had involvement over 8 years, particularly of total colon involvement in ulcerative colitis, we will start screening them earlier and screening them more often. Generally, we'll do a colonoscopy every 2 years and look for any changes. And they have a higher risk than the general population. With a little bit different colon cancer, they don't have colon cancers that develop as a polyp. It's usually a focal cancer. So in those patients, we really do depend on a very good prep, because the changes that we see that are precancerous can be very subtle and easily missed if the prep's not adequate. So that's why it's very important to tailor the prep to the individual patient, to try to encourage them to get a good cleaning out so we get a good look. Those are the generally increased risks, and we mentioned the people that are overweight, because people that are overweight actually have a higher risk for a lot of different GI malignancies, as do people who smoke. And although the screening protocols do not include them, that's something that we certainly consider as a possibility, particularly if they have any changes in their bowel habits, bleeding, or any other symptoms.
Is there anything that someone can do before they ever go in? I mean, when you're talking about diet, exercise, things like that, are there some things they can do to prevent developing polyps or to prevent developing colon cancer to begin with?
Oh, absolutely. There are a lot of different things that play a role, and this kind of goes into the multifactorial things that can lead to colon cancer. So when you look at colon cancer, it's hard to say that there's one general precipitating factor. It seems to be both genetic and environmental. For the genetics, it's a certain subset of people, but the vast majority of colon cancers are sporadic. Is at least 60%. They're not associated with any known genetic abnormalities. So there are other factors. Diet is important. So we know a beneficial diet is one high in vegetables and fruits and low in dietary fat. Red meat is thought to be bad, and there are studies that show that for every 100 grams of red meat in your diet a day, the risk for colon cancer goes up about 20%. The cancers associated with red meat appear to be more in the lower colon and rectum than over on the right side of the colon, and that's an association that we don't really understand. Exercise is important, as is obesity. So exercise is a very good way to reduce your risk, and it's thought that actually daily exercise may reduce your risk for colon cancer about 50%. Likewise, obesity increases your risk for colon cancer twofold over the general population. So daily exercise is beneficial. There are other dietary supplements that seem to be helpful, although these aren't necessarily recommended by the cancer societies, but studies over time have shown that they're helpful. One of which is vitamin B6, folic acid, generally 2 milligrams a day, is helpful. And then there's the aspirin. And most recently, the U.S. Preventive Task Service's recommendations have added aspirin back to their recommendations as preventive for colon cancer. So the aspirin is a totally different ball game. And is thought to be helpful in preventing both polyps and colon cancer. Now, the dose of aspirin and how long you take the aspirin is sort of up in the air, but there are pooled studies that show any dose of aspirin, it can be 81, 325 milligrams, if taken daily, can prevent colon cancer after 8 to 10 years. Now, a lower dose of aspirin and a shorter duration, like a baby aspirin every day for about 3 to 4 years, can help prevent polyps, but you need a longer duration and a higher dose, most likely, to help prevent colon cancer. The higher the dose of aspirin, the better the beneficial effect over time. However, when you increase the dose of the aspirin, you increase your risk for gastrointestinal bleeding. So, with the recommendation comes the fact that, especially with these recent studies, that the risk for GI bleeding is, I think, artificially low. They mention 1 to 2 GI bleeds per 1,000 patient years. I think it's actually higher, being on the receiving end of the GI bleeding coming into the ER, I think these estimates are underestimated. So you have to, with any medication, you have to weigh the risks and the benefits. But aspirin's been re-added, particularly a baby aspirin. So the U.S. Preventive Test Services recommend a low-dose aspirin, which is typically 81 milligrams, and particularly if you have a risk for heart disease or stroke, because it's beneficial for both. Now, if you have a history of abdominal pain, history of ulcers, it's probably not a bad idea to consult with your gastroenterologist before you start the aspirin, and probably not a bad idea to take a proton pump inhibitor, one of the anti-ulcer medications, at the same time you take your aspirin, particularly if you're at increased risk. If you're older, previous history of peptic ulcer disease, sicker in general, have a history of cirrhosis, or any chronic medical condition, you're going to be at an increased risk for ulcers. So it's probably best to take an over-the-counter proton pump inhibitor like generic omeprazole, generic Protonix, once a day along with your aspirin to help protect your GI tract. Unfortunately, the aspirin can also cause ulceration of the small bowel and colon. So when you're on the aspirin, if you develop pain, any blood in your stools, black tarry stools, you should probably stop the aspirin and consult one of us.
I know that that's something that is readily available, and they sell the low dose, they sell the baby aspirin, it's all over the place, it's very easy to get. But that's something that, as you said, you really should ask your doctor before you start on any of those kinds of regimens. Even though it's a low dose, it's a baby aspirin, it seems like it's just healthy all the time, you shouldn't just decide to do that on your own and start taking that every day. I always like to kind of slip that in there.
Very true.
It's, again, it's easy to get. Everybody talks about the benefits of that, but there could be some risks as well.
And the other thing is, you know, a lot of these folks nowadays are on a blood thinner for various reasons. So if you're on an aspirin causing an ulcer and a blood thinner that thins out your blood, if you develop an ulcer, you may have a very brisk bleeding episode. So it's best to maybe talk to your cardiologist and your gastroenterologist at the same time. So these are not taken lightly just because they're over the counter.
Absolutely. What about probiotics? Is that something that's a good thing?
Yes, they're actually they're probiotics and they're prebiotics, and the probiotics are thought to be the good bacteria for your GI tract. So these are actually beneficial to the colon lining, and there's certain bacteria that we think are good for your colon, i.e. normal metabolism, normal turnover of the cells in your colon, less likely to develop into colon cancer. And these are the lactobacilluses, the Saccharomyces boulardii, that are thought to be good. And these are in most over-the-counter probiotics. Lactobacillus GG is one of them. And then there's some other bacteria that we know are harmful to the colon, and these are generally the E. coli's and the things that tend to cause disease. So a probiotic once a day with one of the 3 good bacteria is probably not a bad idea. And then there are some dietary habits that also promote growth of the good bacteria. And these are the prebiotics, and these are things like onions, leeks, asparagus. These types of foods have been shown to be beneficial because they stimulate production of the good bacteria in your GI tract. And there's no great data that shows that this prevents colon cancer, but the studies have shown that it could very well be beneficial.
Is there any downside of taking probiotics every day, or is that something, I know it's encouraged sometimes when you're taking antibiotics to also take some probiotics to kind of keep your system working well, but is it okay to take every day?
I think so. You know, some people don't tolerate them well, some people get diarrhea, some people get constipated, some people get gassy after they take them. So if you start having any untoward symptoms, stop them. But in general, they're relatively safe. And these are the bacteria that would normally occur in your GI tract. We're just increasing them in number to try to get them to take over. And in fact, we use probiotics a lot for people that have gas and bloating, and frequently with diarrhea, they'll do better. But if things get worse when you're on them, of course, stop them. But in general, they're pretty safe and well tolerated. And as you've noticed, anytime you go to the grocery store or the pharmacy, there are a ton of them out there.
Yep.
And each of them tries to boast that they're the best and super potent and super powerful, but the absolute numbers of the bacteria is probably not that important. It's just what's in them. And so they're probably all okay. If they're too expensive, go to the one that's cheaper.
There you go. That's good advice. It's time for us to take another quick break. If you have a question or a comment, certainly give us a call. We'd love to get you on the air when we come back with more Health Talk.
Your word is gastroenterologist.
Can I have the definition?
A physician who specializes in diseases of the digestive tract.
Can you please use that in a sentence?
When stomach pain persists, you should see a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
G-A-S.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Hello and welcome back to Health Talk. I'm your host, Angela Baracco-Eddy. With me tonight is Dr. Carl Speer. He is a board-certified gastroenterologist with the Baptist Division of Gastroenterology Associates. You can find him at Baptist Hospital as well as Gulf Breeze Hospital and their medical parks in Navarre and on 9 Mile Road. You can also find him at the Endoscopy Center on Davis Highway. And the Endoscopy Center, their website will be on the program throughout the evening, www.endo-world.com. There it is. And that website has all the contact information for the various offices, how you can make appointments, some information about the various physicians. So if you have any questions that you think the website can assist you with, then definitely check that out. It's a great website. It's got a lot of information. And of course, you can always call the Endoscopy Center. They're very helpful there, and they would be more than happy to answer any questions that you may have or steer you in the right direction. Tonight's topic is colon cancer screening, and we've been talking quite a bit about colon cancer, the various screening methods that are out there. We'll talk about that in a little more detail coming up. We've talked about some of the ways you can prevent colon cancer, some diet, exercise, some things to avoid, things like that. And we're going to talk about a couple more of those things to avoid and what problems they might cause. And there's some things that you've probably heard before you should probably avoid. Let's talk about alcohol and smoking.
Yes. So cigarettes are just bad for any type of cancer, particularly colon cancer. And it seems to be worse in women for some reason. Their risk is increased about 40% if you're a smoking female. Smoking also affects a lot of the other GI cancers that we follow: esophageal cancer, gastric cancer, particularly pancreatic cancer, but also colon cancer. So if you're female and a smoker, I would seriously consider quitting. But it also increases the risk for colon cancer in men as well as the risk for lung disease and emphysema. Alcohol is interesting, and studies on alcohol and colon cancer are all over the map. The general scenario is if anything over 1 alcoholic beverage a day in various studies has been shown to be harmful. Now, keep in mind, the Physicians' Health study by Harvard showed that 2 or more, but not more than 4 alcoholic beverages a day is good to prevent the risk for heart attack and stroke. However, for colon cancer, it looks like for most studies, anything over 1 alcoholic beverage a day is harmful. There is some older data that shows that distilled alcohol, like the gins and the vodkas, is worse than the other alcohols, particularly beer and wine. There is some data that shows that red wine in men is beneficial, but it's still not more than 2 glasses of wine a day. And generally, the more you drink, even if it's red wine, the increase the risk for colon cancer. So if you're a drinker, pick red wine, particularly if you're a male, and limit it to 1 glass a day. But there's so much variation in the literature out there as far as alcohol is concerned. These are not hard and fast rules, but in general, overuse of alcohol is bad for your colon, and particularly if you have a predisposition to liver disease, you want to limit the alcohol, particularly in today's times if you've had a history of hepatitis C, which is rampant, or any other liver disease. If we tend to be overweight, we may have fatty liver, so the alcohol will be bad in any combination of diseases of the liver. Generally, the liver does okay if it just has 1 insult, but if you add 2, it doesn't do so well. So if you can eliminate or limit the alcohol if you've got underlying liver disease, that's probably a good thing.
And it's, again, one of those things, you know, and just having the discussion this evening, it may be good in some instances, but then there's other systems that it affects adversely, so you sort of have to be careful. It might be okay for colon cancer, but it's probably not good for, as you said, liver, or probably not good for something else. So again, it's sort of a fine line, and it's a little bit, everything's connected, so it all works together. You have to be a little bit careful. But smoking pretty much across the board, it's bad for everything.
Right. And there's some other things that are associated with an increased risk. People that have had their gallbladder out, a cholecystectomy, seem to be at increased risk. Diabetics are at increased risk for colon cancer, and for them, if they've been insulin dependent as opposed to just having their diabetes managed by oral medications, their risk is higher. And interestingly, women, or actually spouses of someone with colon cancer, tend to have an increased risk for colon cancer. There's no genetic relation there, typically, hopefully, if you're not married to somebody you're related to. So you wonder how the environmental and maybe the dietary factors play a role, because you're pretty much eating the same thing and living in the same environment. You have the same allergens and whatnot. So that's an interesting association, which sounds like it really points to a significant environmental or dietary component to the colon cancer.
My first thought when you said that was, well, they're eating the same thing, so it sounds like it's dietary, or it could at least possibly be dietary.
That may be the key.
That's interesting. So we've talked about several of the different risk factors. We've talked about a lot of the things you can do to prevent. We've talked about some of the things that could lead to some of these bad things like smoking, alcohol, overuse of alcohol, things like that. So there's a lot of things that we can do lifestyle-wise to try and prevent colon cancer. But of course, regardless of what you're doing lifestyle-wise, even if you're healthy weight, healthy everything, healthy diet, good exercise habits, a screening colonoscopy is still very, very important. And again, that magic age, if you have no risk factors, no family history, anything like that, is the age of 50. So if you're 50 years old and you haven't scheduled your screening colonoscopy yet, make that your New Year's resolution. Have one done. It's the beginning of a new year. Make part of that resolution to keep you healthy, because again, if you do find something in a screening colonoscopy, for the most part, you can fix it, right? Let's talk a little bit about that. What happens during the screening colonoscopy that if you find something, what are the various ways that you can address one of those problems or concerns right then?
Well, hopefully on your screening colonoscopy we don't find a cancer, but if we do, the earlier we catch it, the better we are. So you want to catch a colon cancer before it's metastasized anywhere else. So if a colon cancer spreads, it's going to go to the adjacent lymph nodes first, and then probably to the liver, maybe to the lung. but it's going to be the adjacent lymph nodes. So if we can catch a cancer early, get it removed, if there's no evidence of spread anywhere else, that's the optimal benefit. And then your risk is still high for a recurrence later or a synchronous cancer, but much less than if it's spread anywhere else. The best scenario is to find polyps along your colon if they're precancerous, because they are at risk over time of turning into cancer. And we think for a typical adenomatous polyp, particularly if it's less than a centimeter, that time period from polyp to cancer is probably about 10, maybe 15 years. So we still have some time, but if we find polyps, we just take them all out, and that reduces your risk significantly. Again, we can't emphasize the importance of a good preparation of your colon so we can see them all and get them all out. And then depending on how many you have and the pathology of the polyps, we would then make a recommendation as to when you come back to have another one. If you've got lots of polyps, it could be 3 years. If you don't have too many, and depending on the size and the pathology, we may bring you back in 5 years. If it's a normal colon and you don't have any polyps and there's no family history and you don't have any other risk factors, the next interval would most likely be 10 years. So there are various things that we find. Sometimes we find ulcers that are actually colon cancers that ulcerated, but we never really know what we're going to find until we take a look. But for the most part, statistically we can deal with whatever we find favorably, and it's typically not a cancer. But the longer you wait, the higher the chance of a colon cancer that could have been preventable turning into a colon cancer that's no longer preventable and may have spread somewhere else. Again, we think with screening colonoscopy, we have reduced the risk for colon cancer about 30% over the last 5 to 10 years. And when we catch colon cancers earlier, even if they've already spread, the earlier we catch them, the decrease the risk of complications later from that cancer. So the sooner the better.
Absolutely. We've had a call come in, so I want to get to the phone. Hello, and thank you for calling. Do you have a question or a comment? Oh, I hear your TV on in the background. If you'll turn that down, it would be a lot easier. And then if you have a question, we'd love to hear it. Go ahead. Hello, are you there?
Hello. Yes, ma'am. I want Dr. Speer to speak about C. diff.
C. diff.
C. diff, yes. So Clostridium difficile is a bacteria that can cause severe diarrhea, usually bloody diarrhea, significant pain. It probably lives in the colon naturally, but particularly when you're on antibiotics or otherwise ill, it can take over in your colon, if you will, and can cause significant problems. Sometimes if it gets really bad, we develop a condition called toxic megacolon, where part of the colon just dilates and eventually becomes necrotic and essentially dies. And for those folks, they have to have their colon removed.
I'm on vancomycin now, and but I'm finishing up the regimen now. But I'm doing better.
Good. So you had C. diff with that?
I've had C. diff.
Oh, you're on vancomycin. I'm sorry, I didn't hear you. Okay. So that would be one of the treatments for C. diff.
I was on clindamycin for a long time, and you know, it gets rid of all your good bacteria, and that's what I'm going through right now.
Okay. And so clindamycin is actually the antibiotic that's most strongly associated with Clostridium difficile diarrhea.
Right. Yeah.
So, you know, particularly for you, if you require another antibiotic, I wouldn't pick clindamycin. And I'd probably take a probiotic along with whatever antibiotic you need.
I'm on probiotics too.
Okay. And then hopefully you'll get better. If it recurs, we do have the fecal transplant available, where we actually transplant stool into your colon that is from a donor person, and it's very effective for treating recurrent C. diff. Hopefully you won't have a recurrence, but sometimes it's hard to treat and comes back later.
That's what I was told, yeah.
So it's probably beneficial to stay on the probiotic and try not to take any other antibiotics anytime real soon if possible.
My question also is diet.
Mm-hmm.
I've noticed that you were talking about red meat.
Right.
I buy ground chuck, and I don't know why. That seems to help me. I don't know if it's the probiotics doing it, but could you kind of give me an idea about what I could eat?
Well, again, to prevent colon cancer, for the C. diff, it probably doesn't make that much of a difference. Again, I'd take the probiotic. But for red meat in general, for colon cancer, you want to avoid the red meat if you can. You want more fruits and vegetables, probably more fiber, but it looks like the studies on fiber are probably not impressive as we once thought.
Eat a lot of fiber.
Mm-hmm. And that'll keep your bowels moving, which is helpful. And that's probably the best you can do. More fiber, more fruits and vegetables, less fat, less red meat, and you should do okay. And you're right, it's probably the probiotic that caused the improvement, probably not the ground chuck.
Well, that was the first thing the druggist put me on, because they didn't have vancomycin available.
Mm-hmm.
And when I walked in and started asking him about it, he said, well, I'm going to put you on probiotics. And I started taking that, and I'm on my second box now.
Yeah, and I'd probably stay on the probiotic indefinitely in your case. I just keep taking it.
Okay.
Yes, ma'am.
Okay, I appreciate you talking to me, because that really has, I've been worried about it, but my doctor seems to think I'm doing better, so that sounds good.
Well, good. And particularly if you have a recurrence of the C. diff, you probably ought to see one of us. And the fecal transplant's available, and it works amazingly well. I mean, about 96 to 98% of people that have it, even if it takes 2, usually get rid of the C. diff, unless they're back on antibiotics.
Well, I have a lot of food allergies, and I think that's what really bothers me. I have to watch everything I eat. And I ate a lot of tomatoes and, stuff like that, and I'm just wondering, do you think that would aggravate it?
Probably not. Probably not.
Okay. Well, I appreciate it. I really enjoy your show.
Well, thank you.
Thank you so much for your call. We appreciate you calling us this evening.
Thank you. You have a good night.
Thanks. You. You too. And I know that we have a couple of calls holding. Please continue to hold. We're going to take a real quick break, and we'll come right back to you with more Health Talk.
Your word is gastroenterologist.
Can I have the definition?
A physician who specializes in diseases of the digestive tract.
Can you please use that in a sentence?
When stomach pain persists, you should see a gastroenterologist.
Could you tell me where I could find one?
The Endoscopy Center on North Davis Highway has a highly trained staff of 12 gastroenterologists who are ready to serve all of your gastrointestinal needs.
G-A-S.
Your first date. Your first job interview. Your wedding day. Your first baby. The firsts of everything can be scary, but you survive. Your first endoscopy may increase your chances to survive. Colon cancer screenings can save your life. If you won't do it for yourself, do it for the ones who love you.
The Endoscopy Center of Pensacola is an ambulatory care center designed with the patient in mind. Conveniently located on North Davis Highway, the center specializes in outpatient endoscopy. This is the direct visualization of the digestive tract with a video camera. Several different types of procedures are performed involving the esophagus, stomach, small intestines, rectum, and colon. All procedures are performed by board-certified gastroenterologists. Ask your doctor about the Endoscopy Center or call 474-8988.
Hello and welcome back to Health Talk. I'm your host, Angela Eddy. With me is Dr. Carl Speer. He is a board-certified gastroenterologist with the Baptist Division of Gastroenterology Associates. Tonight's topic is colon cancer screening, and we've been talking quite a bit about colon cancer and the screening options that are available, and it is a live show. We were asking for calls and questions. If you have anything that you'd like to share or you'd like to ask the doctor, tonight is a great night to give us a call. 432-7768, or outside of the Pensacola area, the toll-free number is 1-800-950-2522. And before the last break, we did get another call coming in, so I want to make sure that we get to the phone. I've got you on there now. Hello, and thank you for calling. Do you have a question or a comment for Dr. Speer?
Yes, I'd like to know at what age you don't need to worry about having colonoscopies anymore.
Great question.
That is a good question. When do we stop? Is there any family history of colon cancer in your family?
None.
And have you had polyps in the past?
None.
Okay, good. So the U.S. Preventive Task Force recommends stopping at 75. However, people are living longer these days, and particularly if people have a family history of had polyps, we will generally continue into the 80s. If someone is generally healthy, no other risk factors, and have never had polyps, probably stopping at 75 per those recommendations is appropriate. If you're otherwise fairly ill and have chronic medical problems, and the risk of, say, essentially the risk of dying of colon cancer is less than your risk of dying from some of your other medical illnesses, we would stop sooner. Because then the benefits of a screening colonoscopy really are less than the disadvantages. And unfortunately, if you're sicker, the risk for a complication from a colonoscopy is greater as well. So if you're healthy and have never had a problem, we might stop earlier. If you're unhealthy, we may stop earlier. But for the average person, particularly if you've had polyps along the way, we would probably continue into the 80s. I'll take that back about the healthy person. The healthy person's probably going to live longer, so we would probably continue into the 80s as well, just because you're healthy, and we would anticipate that you're going to probably live into your late 80s, maybe 90s. So
as you get older, your percentages doesn't diminish?
As you get older, your percentage of having polyps and colon cancer is increased. So we don't want to miss that. The worst thing would be for somebody that we stop early and then they develop a colon cancer and die of complications of the colon cancer when they're otherwise healthy. So with a healthy person, we would probably continue at least into the early 80s. Maybe not mid to late 80s, but probably early 80s.
All right, I appreciate that.
You're welcome. Take care.
Thank you very much.
Thank you very much for your call. We appreciate it.
All right, bye-bye.
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 Great question. Oops, there we go. Great question, and I appreciate the call, definitely. I think that we have another call holding, so I want to make sure I get back to the phones. I was hoping I didn't push the wrong button and lose them, but I think that we're still good.
Oh, good.
Hello, and thank you for calling. Do you have a question or a comment for Dr. Speer?
Hi, yes. Just a quickie, because I know time's getting short. I want you to know that you really reached us out here. It's practical, usable information, not just a lot of mumbo-jumbo procedural talk, but useful information. The other thing is, I'm coming up for one soon. Once you're on the table, how long does it take?
Good question.
We all go at a different speed, actually.
And then give or take whatever you find as you're going.
Right. And so the length of the procedure is longer if we have to take out multiple polyps. But generally about 20 minutes is kind of the average, somewhere between 15 and 20 minutes. A little longer if we take out a lot of polyps. Essentially the longer we take, the better look we get. And the risk and the chances of finding polyps, if we aren't in a rush and kind of get a good look, is much more thorough, if you will. So 20 minutes is probably the average length of time.
Yeah. Well, I want you to take your time. I'm coming up next week.
Oh,
take
good.
Your time to do what you need to do while you're there and ends. I got to come back and come in again.
Absolutely.
Great. Look forward to it.
And again, thank you. You really reached a goal. You took your time wisely. You gave us a lot of information that is useful. Thank you.
Well,
wonderful.
So. Thank you.
Thank you so much for that, and thank you very much for your call. Good luck next week.
Thank you.
Thanks. That's such a great question. It's such a nice thing to say and to bring up, just the importance of the prep. I know that's something that seems to be the thing that people tell me The worst is the prep. The procedure itself, I slept through. It was no big deal.
Right.
They're out. That was nothing. It's the prep that's it. But I also hear it wasn't nearly as bad as I expected it to be.
Well, that's the main thing, because so many people are afraid of whatever it is, and so that's a real barrier to them coming in. Once they have it once, they typically say, wow, that wasn't nearly what I expected. And then they tell their friends, and their friends come in. So it really is, I think, a pleasant surprise, if you will, and much less traumatic than most people think.
Well, and I know that 15, 20 years ago, it was a lot more difficult then, and it's gotten so much better. It's gotten to be so much easier. You don't hear those horror stories anymore.
Right, and our preps have gotten much easier. And so we tailor it to the patient. Not everybody is a candidate for the same prep, but the preps are pretty basic, and we've made them a lot simpler. Whatever we give you these days, we kind of divide it between the night before and the morning of the procedure, and we tend to get a better prep that way. And so whatever we give you these days, you'll do essentially half of it the night before and half of it the morning of. But it works.
And screening colonoscopy is so, so important. Again, it is something that can save your life if they are able to find something, prevent the cancer from developing. Of course, that is always better than having to come in and treat a cancer once it's there. So if you need a screening colonoscopy, if you are past that magic age of 50, make sure you give them a call, give your doctor a call, schedule a time to have that screening colonoscopy done. It's something that's a relatively easy procedure, and it could very well save your life. That is it for us tonight. Thank you so much for joining us. We look forward to seeing you when we come back with more Health Talk.